well, what if I just pay the whole thing right now? She goes, well, if you do that, I'll take 30% off. They want base prices to go up every year because revenue has to go up, earnings has to go up, etc. Medical adjudicates like as if it was an improvement from the Wells Fargo wagon of the 1800s. 60% of payments are still paper check. CEO of Blue Cross Blue Shield, Louisiana, in his infinite wisdom that day, in his deposition, and then he took it on to the courts, said, just because we gave a prior auth does not create a commitment to pay. An employer that you work for, or a plan that's fully insured, pays between $1.20 and $1.40 for that dollar of healthcare. The providers in America today are getting somewhere on around 80 cents on the dollar.
Hey guys, welcome to today's episode of the Will Soliman podcast. Now, in the last several months in 2025, we've been hearing a lot about pharmacy benefit managers, about payers, healthcare insurers, about drug pricing. It's been all over the news. Just yesterday, the Trump administration announced a big announcement about the deal that they made with Pfizer, one of the largest pharmaceutical companies in the world, around trying to find ways to curb drug pricing. Today, we have a guest who lives in this world, actually just bought and sold a PBM. So I'm really excited to talk to him. His name is Mark Newman. He's the co-founder and the CEO of Nomi Health, who's been on a mission to rebuild America's healthcare system. They serve a lot of different stakeholders, providers, employers, and patients. He is a recognized healthcare innovator and an entrepreneur, and he actually is one of the co-founders of Nomi Health. And recently, until his leadership and its inception in 2019, Nomi Health had focused on creating a more direct and transparent healthcare experience for people that have, really they're just self-insured folks. And so he's covering today over 19 million lives, which is amazing. Mark has appeared in Fortune, Reuters, Wall Street Journal, and he's also been recognized as a leader within the healthcare space by Becker's and by others. And so I'm really excited to have Mark Newman join the podcast. Mark, welcome to the podcast.
Thanks for having me.
Yeah, my pleasure. So Mark, it's been a very fascinating year this year with everything going on in healthcare and drug pricing, like I talked about. Pharma, it's always something you hear about, especially, myself as a former pharma exec. People constantly bombard me with those questions about why are drugs so expensive and, why is the healthcare system so complex? But you decided to go into this space, right? And you founded Nomi Health. Tell us a little bit about your journey, how you got to where you are today. What got you interested to working in the PBM space, the healthcare space?
So my entire background since I started my first company in college has been in employer tech. So all I've done is always work for employers. I built a company called HireVue for a long time, which was spent 15 years doing that, which was the largest video assessment platform for large employers. So we worked with all sorts of HR leaders to say, all right, here's how we're going to transform your hiring, giving people a voice, giving people an opportunity to not just be a resume or a profile, tell their story, demonstrate their ability to work, build great teams. HR is my village, right? I love it. I love what HR and benefit leaders and employers have to do every single day for the people that work for them. And then in funny ways, life happens, right? We always have those first-time healthcare experiences that come about. And in my case, it was the birth of my son. So he's 10 years old now, and I was CEO of HireVue at the time. And this lovely person comes into our hospital room, says, "Congratulations on your new baby." And I'm like, "Thank you. Who are you?" Because not a doctor or a nurse. And she's like, "Oh, I'm from finance. I'm here to talk to you about your bill before you leave." And I sat there, and it's like,
that's always nice. That's a nice way to kind of pop out the happiness and the joy there, just to remind you of what you owe.
Sure, but it's like this is like your first life experience really on healthcare, right? As your first child, or where you're the one in charge. And I was 30 at the time, and I'm like, all right, I've been relatively healthy and done okay, and here it is, it's coming. And so in that case, I said, great. She had no idea of my ability to pay, who I was, what I was able to do, whatever. She just knew that I had an incredibly high deductible health plan, but we were in tech. We had a high deductible health plan with fully funded HSAs. We were great, kind of on here. And I said, okay, I'm ready for this moment. What is it? And she goes, oh, well, if you remember the novel innovation of the last 10, 20 years, it was we did a bundle. We worked with your insurance company. It's one flat price, you know, you name it. And I said, okay, what is it? And she goes, $4,500. All right, what are my options? And she goes, oh, well, we do payment plans and we do this and we do that and all the kind of various parts. And I go, okay. Well, what if I just pay the whole thing right now? And she goes, well, if you do that, I'll take 30% off. And I sat there, and that wasn't a healthcare problem. That was a good old fashioned business problem. And, you know, and it was like that, it kind of hit me in the face because I'd just gone through the typical, you know, nightmare of the CFO, CEO, where healthcare costs just jacked up. I had 400 people working for me, just went up another 10, 12% without any idea why, no reason, people just saying whatever it might be. Yet I showed up with money and I got a 30% lower price. And that was because I took, you know, in hindsight, in learning more, I took them out of the collection business. I simplified their business. I simplified their act of getting paid for a service they delivered, and went on this journey. And unfortunately, I had a front row seat, you know, being able to go talk to people about this because we did almost, you know, all sorts of hiring programs for all the major payers and all sorts of other things because of who we are and what we did. And I went and talked to them and said, hey, this just happened. Like, I would like 30% lower cost healthcare. Could we do this together? And they said, you know, pound sand, get out of my office. That's not how it works. Let me tell you how the world works. And I realized who else would be upset about this. Oh, wait, all I've been doing is hanging out with HR people my whole life. I'm going to go talk to them. And, you know, I'd never thought I'd build another company. We had a successful exit and outcome there, but this problem just kept gnawing at me and proving it over and over again. So in 2018, 2019, decided to grab a couple co-founders together and go fight like hell to go build this thing.
So tell us a little bit about, I guess, what you do now, like what, you know, and kind of talk the audience through, because not everybody maybe is as familiar, the different type of insurance. There's obviously there's people that are covered by Medicare, Medicaid, people that are privately insured through their employers, they're self-insured. Maybe explain to people that, you know, the differences and kind of who you focus on.
For sure. So Nomi Health today is the operating platform for self-insured employers. So there's obviously Medicare for the old, there's Medicaid for the people who need extra support. There's fully insured, there's individual, there's marketplace, but 100 million people get their health care through their employer that are self-insured. It's about 90+% of organizations, 200 employees and above. The way we think about it is that these self-insured employers who support working age families in America, you know, they spend about $1 trillion a year on healthcare now across pharmacy and medical. Okay, it's a ridiculous amount of money, and it goes up every year. Well, if they're spending about $1 trillion a year on healthcare, what that means is that they spend about $10 to $15 trillion on other stuff that they buy in their businesses. And for some reason, we treat them as if they're like too stupid to understand how to buy $1 trillion of healthcare. And that's the box that we want to break open. So we take a very open, transparent approach to say, first, let's be the platform for analytics so that you know your spend, where you spend it, what you spend it on, how you do it, how you could do it differently. So we own Artemis Health, which is the largest analytics platform for self-insured plans. We've built our own direct provider payment system to replicate my experience, right? Where me as an employer would happily pay a provider directly to capture that lowest cost savings to solve that business problem for them and go do it. So we have our own bank trust and direct provider payment network. And then last, we partner with providers and pharmacies and everybody across the entire country to say, listen, like, what's the real price of healthcare when we simplify your business? And we partner with them across the country and launch either full replacement networks or ancillary networks or whatever it might be for people to tap into.
And, you know, I think a lot of Americans want to understand, why is the healthcare system in the U.S. so complex? You know, why are there these middlemen, and why are these situations that, you know, you see on the news all the time with people just struggling to get access, you know, where it necessitates having, you know, services like this? Maybe kind of explain to the audience, you know, how the U.S. healthcare system works.
Understand that U.S. healthcare works the way it is because it's a high ticket item. It's not as expensive as buying a house, but imagine if mortgages didn't exist to buy houses. What would we do? Right? But when it comes to healthcare, if you're thinking about $20,000 to $50,000 a year of expenses for somebody and their families, I feel like what we have to remember is that health insurance payers, PBMs, you name it, are essentially giant financing engines right? And PBM, giant financing vehicles for people that have to be able to buy a high ticket good in some sort of organized fashion with multiple funders, right? Whether it's the individual or the employer or whatever it might be. It's one
Right.
bucket, right? Like it is a complex financial management system. Okay. But on the other side of it, and the curse of it, is that it's also a cost plus system. And the people that make their money on it make it on like on making sure that like data is asymmetric, meaning data is different for everybody, that it's a cost plus model. That's so like they want base prices to go up every year because revenue has to go up, earnings has to go up, et cetera.
Right.
And that people, because it's not a core component of everybody's life, they just kind of outsource the management of it to other people, and so they can take advantage of it. So you got financial system on one side, cost plus system on the other. But like,
Right.
take it even like kind of day-to-day life. Think about a restaurant. You go in with your family and your wife. You have an incredible dinner. You get it. You look at a menu. Maybe it doesn't have prices on it. You just kind of pick food. Okay. And you go in, and at the end, the way it operates today in healthcare is like you would get a bill. It wouldn't even tell you like what it was, and the person that presented you the bill would say, "Pay whatever you think." Right? Like like restaurants can't operate this way, stores can't operate this way, hotels can't operate this way. Nothing can operate this way, but medical healthcare operates this way because a provider delivers care. They have no idea when they're going to get paid, how they're going to get paid, who they're going to get paid by, how much they're going to get paid, and how much they're going to have to fight and work to get paid that amount of money. And so as a result, the only thing they can do is price in that risk of non-payment and business complexity, which then gets passed on by cost plus insurance companies saying costs are high or whatever for an end state consumer that just has to suck it up and take it. And
Right.
and that's why like our whole approach is just simplifying things. Know your data, know where you buy it, simplify the business for the provider. Guess what? Magically, healthcare is less expensive.
In the beginning, I think it was actually towards the end of 2024, we saw obviously what happened with the UnitedHealthcare CEO, right? And it was a really difficult situation with Luigi Mangione and what happened there. But you saw that many people, even just, I think it was 2, 3 weeks ago when the case was being deliberated in New York, there were people outside cheering for him, calling him a hero, which to me is crazy, right? But you have this idea by many Americans that he's a hero. What he did is almost like vigilante justice. Why do you think a lot of Americans feel that way?
People are angry. Like it was the wrong way to show it. It was the wrong way to, like what happened was a complete travesty. But like but you kind of exclude out the actions of Luigi with like the reactions from the public, right? And the reactions from the public, it was like people are angry, they're upset, they're tired of being lied to, they can't afford, like, I mean, it's akin to, I think it's coming on like the cost of power and electricity going up because of data centers, right? That came out yesterday as well.
Right.
So you have housing going up, you have groceries going up, you have power going up. At least you have kind of some ideas about why. Healthcare just goes up. And people have no idea why, and they're like, and it makes no sense either. It's not like sometimes if you charge your cell phone, you would pay one price versus if you charge your computer versus if you do this versus if you do that. Like it makes no sense. One person can get a lab test and, or 10 people could get the same lab test and have 10 different prices. So you just feel lied to. And when people are feeling lied to, it doesn't matter if it's a politician. It doesn't matter if it's an insurance company. It doesn't matter if it's a this. At some point, they break. And we have to take it as a wake-up call that we better do something. And like you see a lot of actions like that are hopefully going to continue about we better do something about this.
Yeah. Yeah. No, I completely agree. And I think, like you said, it was really, to me, it was a wake-up call for the country. Again, nothing justifies what he did, but it just reflects the fact, to your point, that a lot of people are really angry about this. And I think that what people don't understand is it isn't necessarily just one player, right? You can't just put all the blame on UnitedHealthcare, right? And you kind of brought up some of the other stakeholders involved. I know for myself, again, I kind of come at this from a different angle, working for many years for pharmaceutical manufacturers. And I could tell you that The pharmaceutical industry, they're in the business of making sure that patients get access to the medications that they're trying to sell, right? That's a value add for the company, right? At the most selfish level, they make money by making sure that patients get access. So they do whatever they can to streamline access. The hiking of the pricing, oftentimes I can tell you, and I've sat on many of these conversations, when pricing gets set in a pharma company, we have to calculate the loss that we're going to incur and the factors involved because of the middlemen, the PBMs. That's the truth.
Totally. Yeah.
You know,
Gross versus net in pharmacy is absurd.
yes, yes. One of the businesses I had, I owned a business called US Pharmacy Lab, and it was a pharmacy, that had compounding as well. And, we did a lot of stuff in the country. And I could tell you that it was eye-opening to me when we had the business, how reimbursements in some cases were lower than what what it cost you to acquire the medication. So you would lose money if you went through insurance. If the patient just paid cash, in many cases, it was better for the pharmacy and better for the patient.
Right.
Now explain that one to me. How does that make any sense?
Yeah, it doesn't. It literally doesn't. That doesn't make sense. Like it just doesn't. But it's also because the fact of the matter is, for medical care and pharmacy and drugs in America, 90 to 95% of Americans couldn't afford it if they had to pay it all for themselves on their own. Right. Like we have this asymmetry in this system. Right. And, and as a result of that, we have to build up this entire infrastructure of like a financial and banking system, essentially, to help that be financed on behalf of the individual that needs it. Okay. Yeah. And then as a result of that, especially when it started as, like, even if you look at medical and pharmacy, like at least pharmacy adjudicates in real time. Right? Medical adjudicates like as if it was like an improvement from the Wells Fargo wagon of the 1800s, right? And somehow these are like the twins that were separated at birth. And we're like, how did this happen, right? Like 60% of payments are still paper check. And it's because like medical started as a local town thing and then got bigger and then got bigger and then got bigger. It was only a few years ago that United even offered plans nationally, like in the last 10 years. And so it's just been this like fragmented Frankenstein thing that's expanded up. And on drugs, you have this kind of dynamic, but then you have this affordability problem. And now, if the entire industry was simple, meaning, everyone could get $4 generics at Walmart and everyone could buy, whatever at Cubans, and everyone could buy compounded drugs and everyone could do this and everyone could do that. And we just cut the bullshit. Like we just like got rid of all the other noise, we would probably find that our, $6 trillion healthcare system might actually only cost $3 trillion, and like that sounds like an absurd amount of money, but like that's affordable. Like that'd be a huge win. Like if we had a campaign of asking every governor, mayor, and CEO and president, what would you do with $3 trillion? Every single year back in Americans' pockets, kind of on there. I think it'd be a pretty fun campaign. We could pave every road twice, but it's like you kind of go through this. So as a result of that, like every one of these things is like a symptom of the problem, like direct cash pay this, compound pharmacy costs of that, cash rate pay for healthcare, Cubans this, like you name it. They're all symptoms, but we have to figure out people that don't have money, how they can access those prices.
Why do you think in other countries they don't really have this bad of an issue? Now, to play devil's advocate, what I would say is, my background, I'm a scientist by training, and I did a lot of clinical work. Medical outcomes for procedures, general health outcomes in general for the US are better on average than most other countries. Now, there are some exceptions, in Western Europe, there's certain health systems that are on par with the US, but we're considered to be the best of the best, right? I mean, people that come from all over the world to get treated at the Cleveland Clinic and Mayo and Brigham and Women, right, in Massachusetts. So, there's something to be said about the US healthcare system in terms of its excellence and quality, in terms of delivery of care. So some people say, well, that justifies the cost because you don't see that again in other countries, right? And I know tons of horror stories in other countries that people have experienced when they've had to have an emergency surgery, or you're taking certain prescriptions and things like that. So is there an argument to be made for why it costs more here? It's fair that it costs more because you're getting better quality. What do you think?
I think when it comes to healthcare costs, there's also a lifestyle question too, right? Like if you're in other countries and you're walking everywhere because you're in an urban environment and you're doing this and you have a better food system and a better this and a better that, and what, like there are other contributing factors to the overall health of the American population versus other places. Like what's ironic about some of like the GLP-1 transformations that you're seeing is like not every organization needs to pay for it. But in some organizations, they're like, it turns out we needed to lower the net weight of our workforce by 15%. And our healthcare costs, like plummeted, as a result of this, right? It's like we do have a less healthy society than other countries do, right? That's one kind of core thing. And so then it's the like, what system do you want and need when life happens? Like, because we have a lot of, I would argue that in America, we have a lot more ongoing healthcare than episodic healthcare than in other countries. Does that make sense? Like, I don't think you have as much, like, in other countries, it's like you only go to the doctor when you really need it, because you're generally, kind of on this part of it. But then when you really need it, like the life happens part, you want the best possible response when life happens, right? And so we're kind of seeing this, like, it's hard to call it. It's like the up and down the street healthcare problem, right? This like kind of the magically, like Humira magically becoming also, double indications for like irritable bowel. And now magically tech companies that have a really young workforce who don't have a ton of rheumatoid arthritis patients magically are spending millions of dollars a year on Humira for people randomly getting it for IBD, right? Or something like this, which doesn't make at all any sense, which actually could be solved in many cases from a lifestyle change versus going to a really, really hardcore biologic that you're taking from a shot basis on a regular basis. Right. And so we kind of we generally defer to a treatment instead of defer to a lifestyle choice, right? Kind of in here, which clogs up the system, which makes it more expensive. But like, if you need a knee replacement, you probably want it in America versus other places, right? And if you want cancer treatment, you probably want it here versus other places. Right. And so the question is like, how do you take out the middle? You know what I mean? Like, because like primary care visit, cheap, right? Specialty visit, generally cheap. But if you walk out from a specialist visit with an $80,000 a year drug, like, not cheap, and like that's kind of this push and pull that we have to work towards as a country to go figure out.
Yeah, and I agree with you there. I think you're talking about preventative medicine, and I agree. I think there's a lot more we can do as a society when it comes to the food that we eat, even the water that we drink. There's a lot of data about the contamination of, microplastics in water bottles, for example. So I agree with all that. I was referring more to the acute treatment, right? Whether it's a knee replacement or a heart surgery, something like that. In general, you're getting better quality care in the U.S. What's interesting, though, if you look at the mortality data, Americans on average, I think it's for men, it's about 78 years on average is the average age of death. Women, no, sorry, I have the other way around. Women, it's around 78. Men, it's around 74.
Yep.
And if you look, we have been able to increase that by a few years versus about 60, 70 years ago. So there's been an improvement, at least in mortality rates in the U.S. Now, we could argue about the quality of life and things like that, but it looks like the advancements that we've made in medicine have helped. What's interesting, though, is if you look at obesity now in the U.S. is about 42%. Back in, the 1920s, it was, I think, less than 10%. So clearly, obesity has been a big contributing factor. But why was mortality rate worse back then? I think a lot of it is just people were just dying of different things. Back then, people were dying mostly of infectious diseases, starvation before the mass production of food and things like that. Now you're seeing a different kind of, I guess, shift where people are dying mainly of heart disease and cancer, right? But heart disease and cancer, as you probably know, are very much closely linked to obesity. I mean, that's just the truth. It's linked to obesity. So I agree. I think a lot more probably can be done by the government, in terms of education, especially for children. We see now, I mean, increasing rate of children with obesity and types of diabetes, which is terrible. And let's talk about that a little bit around the government. So this year, again, since Trump took office in the second term, him, along with RFK, Dr. Oz, I saw yesterday, is also involved as well, are trying to do a lot to work with pharmaceutical companies. Yesterday, they had some news that they shared with the American public that they made a deal with Pfizer to try to get them to provide some of their drugs, their branded drugs, through Medicaid and then through TrumpRx, this federally available website where Americans can use it as a portal to get their medications. What's your take on that? You think that's legit in the sense that it's going to make a difference, or do you think it's just a lot of bluster?
I think it's legit, and I applaud, like, whether it's red or blue, any administration on like taking a shot. Does that make sense? Like, just taking a shot and doing something. I mean, you also saw Pharma yesterday launch americamedicine.com or americasmedicine.com, to kind of drive all these direct to manufacturer programs. Like, these programs have existed. You could go get, $4 generics at Walmart for the last 15 years. You know what I mean? Like, you could kind of go and do these things. I think what we need to do to make these efforts, like, I applaud the manufacturers, I applaud the administration, I applaud like the pharma. Like, how often does pharma get a pat on the back, right? Like, it's like, no, like, never. Everyone like knows that there has to be something to do here, right?
Yeah.
I think the next step should be an education campaign for Americans around how to buy drugs and healthcare. Because whether it's like, because the natural human tendency, right? Like, we see this every day in like plan operations. And like, even going back to what you said a minute ago around us versus other countries, it's like, if you can remove the structural cost of buying and paying for healthcare, right? Like, you have a plan, you're an employer, and you have a certain number of cancers and NICUs babies and accidents and stupid things that happen, right? Like, that's our world, because we work for self-insured employers. And if you can structurally reduce those costs by like simplifying the lives for providers, you'll save like 25%. Okay. And then what happens is, like, they get rid of copays, get rid of deductibles, get rid of this for people, which is awesome. And you see a bit more utilization, about 8%. You don't see more cancers, more NICU babies, more accidents or stupid things. Right. You see physical therapy, primary care, specialty visits, all the things that people put off because they've had a high deductible and they just don't think it's worth spending $150 or $200 for a high deductible, right, to go to a doctor unless they're like, like really, really, really bad. Okay. I'm kind of on the same with physical therapy. That's on a decision of something between $100 and $200. Okay. But benefits leaders and policymakers say, well, it's only $100. It's only $200. It's fine. People can do that. That's not 90% of Americans. An unexpected $100, $200, $300 cost for 70 to 90% of Americans is a big deal. So even if we have $50 drugs or $100 drugs, on TrumpRx, which will be fantastic. If people don't know how to buy them, or if they could go to Walmart and get it for $10, they'll do it, even if that $10 drug at Walmart costs the employer $200.
Yep.
Right. And so like it's because in general, people don't know how to buy healthcare. So like, what would be cool is seeing, like, can we get all the PBMs and us, I'd say, these financing mechanisms, right, to say, guess what? I can use TrumpRx too. You know what I mean? It's like a point of sale rebate. It kind of operates this way. It's lowest net drug cost, but we made it easy for the employer to have their people use that. And if we pull off that, now you have 100 million people using it, not a million people. It's kind of like the cash pharmacy. It's great for people that have cash. Right? And that's like how, like, we have to solve that problem. And then that education.
Yeah, I agree. I think you hit the nail on the head. People don't know how to buy healthcare. I think that's 100% true. I've said your story before in other episodes, but I have a son, my fourth son. I have five kids. My fourth son, he a few years ago went to the doctor and she said, "Whoa, his left eye is really bad. He can't. He seems like he can't see from based on her eye exam. You got to take him to an ophthalmologist right away." Take him to the ophthalmologist. He does some examination. Says, "Wow, his left eye is he's almost like blind in his left eye." My son, he didn't say anything to us. He was probably about 9 or 10 years old. Anyway, take him to the doctor says to me, "Look, you should take him to get an MRI. He could have a brain tumor." So of course, you're scared as a father. And so my wife, I could see her, she's very nervous. And I was like, you know what? I'm not going to wait. And because I went to the nurse in the office. She said, "Well, you got to get prior auth and it's going to take 3 or 4 weeks and to get the MRI." And I was like, "Look, we're not waiting 3 or 4 weeks to get the answer to this because I need to know quickly." Because, my wife was panicking. Obviously, we're worried, we're concerned. So I ended up going to the hospital, and what you're talking about in terms of buying healthcare or buying services, I was able to actually just get the MRI that day by paying for it cash. Now, if I had to wait for the insurance, wait for the prior auth, maybe people might have thought, "Oh, could you do that? You can actually just pay cash for an MRI." Yeah, actually you could. And I went to the hospital and I just said, "Look, I'll pay for it cash," and was able to get him the MRI. And thank God he's fine. It ended up just being a lazy eye. But as a parent, you don't want to wait 2 or 3 weeks wondering if your kid has a brain tumor. And I think it says a lot about the health system, just in the sense that even in a situation like that, they still got to get a prior authorization, still got to go through a ton of paperwork. And I'm sure you know this, but in the United States, according to the American Medical Association, prior authorization is the number one reason for care delay. It's the number one reason for people getting delays in care. So it's terrible. Talk to me a little bit about what your thoughts are on AI. This is a big thing now, AI in healthcare. You talked about some of the bottlenecks, some of the things that have been slowing down the process. Do you think AI is going to help improve that?
Yeah. So, and what you just said on prior authorizations, and we're talking about AI is a perfect example. And yeah, you went through it and you were one of the lucky ones though, because what's happening now is, and this happened to me and my family. I said, "I'm just going to pay for this. Let's just go do it tomorrow." And they said, if we can do that, however, your insurance company won't cover follow-on care issues if you didn't use them for the front door. And you're like, what the hell? you just want to you wonder why people get upset over this because it's stupid. Right. And you have AI on business process workflow and automations and prior auth. So there's that bucket, right? And then you have AI on the make providers' lives better bucket, right? And I think you see when we think about $1 of healthcare, right? This broader Nomi in my kind of worldview. You think of $1 of healthcare that you and I get a bill for, it's literally not $1 to anybody else. Okay. Now you and I have the means to go pay that dollar bill, right? It's like we got a bill for $1, we can go pay it, and that's how we think, right? That's how we kind of operate. That's what everyone does. No, it's not. An employer that you work for or a plan that's fully insured pays between $1.20 and $1.40 for that dollar of healthcare. And that's just a simple reverse math on medical loss ratio or admin fees, transaction fees, whatever it might be. Okay. So $1.20, $1.40. The providers in America today are getting somewhere on around 80 cents on the dollar for what they're contractually owed versus what they get. That the provider gross to net is better than pharmacy, right? For pharmaceutical manufacturers, but it's still a gross to net problem, right? And that's not ChargeMaster. That is their contractual obligated rate that they signed with United Signabuca, whatever it is, versus what they collect. And they're spending 12 to 15% of their operating budget trying to figure out how to get paid. So you take that down even further, right? And then after that, you think about what's the leading cause of physician burnout? And they're like, it's prior auths, it's note taking, it's tracking, it's justifying the work I just did. I hate it, right? It's like, and they go after it and they're like, "I'm done, I'm out." Right. I did. And that's why I think you see so many doctors joining MBAs, because for some reason they think that's going to help them run a business, kind of on the screen. And so you have AI of you got the prior auth problem, kind of on there, but we think there's 3 core opportunities for AI. The first, obviously, and it's actually funny watching this play out, is that providers have adopted AI faster than payers have. Okay, so now all these note-taking apps are saying, hey, you just saw Will. He mentioned this, and this. You only documented this and this and this. Tell you what, let's add more to your notes to justify your notes. So as a result, like the payers are like, crap, all the hurdles that we used to put up, we can't put up anymore, you know, and so that's why you're seeing this. You're not seeing more utilization. American families don't have more time on their hands to go to the doctor more. Like, you know, what they're seeing is the fact that like providers are like, hey, I'm tired of these games. I'm gonna play better work, you know, I'm gonna play a different game here and go do it. And I applaud them. Good job. Like these people, these companies have taken advantage of you forever. Good job. You should do that. But it's also because they're not treated like adults. They're treated like thieves. Right. And it's like, no, like, you know, so let's treat you like adults, right? You know, like we're on this together. Now let's have like a really open, clean contract and pay and pay you directly on this. And I mean, like, but look at like prior auths. The CEO of Blue Cross Blue Shield of Louisiana, in his deposition being sued because they did all these prior auths that the surgery center got approved, and then they never paid. And the surgery group took him to court, and they got a $450 million jury verdict, you know, for this.
Wow.
The CEO of Blue Cross Blue Shield Louisiana, in his infinite wisdom that day, in his deposition, and then he took it on to the courts, said, well, yeah, I mean, just because we gave a prior auth does not create a commitment to pay. And thought that was like his like out in his deposition and, you know, and in his testimony. And then their lawyers were like, so then why the hell do you have a prior auth?
Exactly.
Like, well, you know, whatever. And so then rather than correcting it, leaned in harder during
doubled down.
Doubled down, got their asses handed to them with a $450 million verdict. Great, they deserved it. And then the other payers, rather than saying, oh, we better fix that and say that a prior auth drives the commitment to payment, put on their websites, just to be clear, a prior auth does not commit us to payment for a service that you delivered. So you're dealing in an industry where the bar just like, they're like, hey, the bar is this low. You know, we heard about the Alaska Airlines flight with the door blew off, and those people were probably pretty sad about the experience. Let's see if we can make it worse, you know, and like just like continue below it. So I think what you're going to see first from like an AI standpoint is equipping the pit fighters and the Rebel Alliance to like do their job better. And that's the providers, and like they should, right? You know, absolutely. I think we can use AI to simplify these business processes, because like prior auth's a total lie. Like 90 some odd % of claims are auto adjudicated. It's just when people don't want to pay. Right. You know, and it's like, you know, so we can use AI and better analytics and data to like expose this. Even so much so as like, benefits leaders operate on cash accounting, yet finance operates on accrual accounting. So like you can't even reconcile and pencil out what spend is on a health plan and an employer, because they don't get payment data, right? And they don't get claims data, or they get claims data late, or whatever this might be. And so prior auths, like, you know, in our model, we try to simplify it. There's like 100 instead of like 5,000. And that's just because like sometimes really expensive things, like you just want to make sure that like the member knows that they're going to go do this. You know, it's like, you know, that like this is a thing, like a cascading level of events. But it's, you know, I think we can use AI, better data, better behavior to kind of equip the Rebel Alliance, like the providers, to justify the care they gave, to streamline the system, kind of how it operates, and to just keep exposing the asymmetry between what a person pays, like on the employer front, versus what the provider gets, and just be heinous around extracting out that friction and waste.
Yeah, I agree. I mean, the only thing I would add to that is with AI, the liability potentially, right, for some of these healthcare systems. I know right now the question is, you know, if something goes wrong and you're using AI for clinical decision making, or in the case of prior authorization, we saw, you know, there was allegedly, I don't want to say the name of the company, but big payer, big insurer had an algorithm set up where the AI was purposely, you know, biased in its sense to actually push back more and do more prior authorization denials. And so then they ended up getting sued. So, you know, I think all of these types of things we have to still figure out, but I obviously I think AI is, you know, is going to play a significant role, I hope, being able to streamline some of these processes. So, well, time
keep in mind,
will tell.
the carriers could say they need AI for that. For years, they've put blocks on payments for certain codes. That didn't require AI. That just required Steve in claim ops to not do it.
Right. Yeah. No, listen, you're right. I mean, at the end of the day, the right intention has to be there. So, Mark, it was a real pleasure having you on the podcast. I really enjoyed the conversation. This was great. We'll make sure to put Mark's information again in the description below the video. So be sure to check it out and visit the website for Nomi Health. Mark, any last thoughts you want to leave with our audience around healthcare, where you see the future of healthcare going?
I mean, obviously, we're biased and think we do great work, but more importantly, I just want everyone to know, like, you can actually do something about healthcare costs. Like, whether you agree with an administration or not, whether you agree with, with the companies or not, whether you agree with an association or not, or whatever it is, there's a lot of people putting like shoulders to the wheel here to say, like, we can do something about this. There are better ways, and there's a real cost of healthcare, and to not just kind of like accept a 10 or 12% increase for the hell of it, right? It's like, no, you can do something about healthcare costs. Know your data, move your money, take back control of it and do something about it. And, if we do that, we have a healthcare system in America that costs half of what it does.
I love that, Mark. I think that's a great thought to leave the audience with. You can do something about healthcare costs. I think that's really powerful. Mark, thanks again. It's great having you.
Thanks for having me.